For many candidates, the path to a passing BCBA score is obstructed by a single recurring point of conceptual failure. That failure point is acceptance and commitment therapy, or ACT. The terminology often leads candidates to misidentify ACT as a mentalistic or cognitive framework, assuming it targets internal states. This diagnostic error ignores the fact that ACT is built entirely upon Skinnerian radical behaviorism. To solve these exam items, you must look past the clinical labels and focus exclusively on the observable contingencies. Identifying the behavioral mechanics of contemporary therapies is a requirement for both the exam and effective clinical practice. Radical behaviorism maintains that all behavior, including private events, is the product of strict environmental contingencies. ACT follows this principle to the letter, relying on operant reinforcement rather than internal constructs. The framework alters behavior by restructuring the client's environment and the resulting schedules of reinforcement. We can translate the entirety of ACT into precise ABC terminology, mapping every clinical move to a specific operant shift. This isn't cognitive reframing, it is a rigorous exercise in operant engineering. Clinical glossaries define ACT as an evidence-based behavior therapy focused on general well-being. For the behavior analyst, this raises a question: how do we measure an abstract concept like well-being without falling into mentalism? We operationalize well-being as making reliable contact with dense schedules of reinforcement. Reliable contact refers to the consistency of the environmental feedback. It requires building functional, predictable relation forcers must be high priority. This means the reinforcers are meaningful enough to maintain a new behavioral repertoire over time. Finally, notice the focus is strictly on positive reinforcement. True well-being is marked by the active pursuit of desired stimuli, not just the temporary escape from aversive ones. Clinical progress is therefore achieved by restructuring the environment to facilitate contact with these specific positive reinforcers. To achieve that shift, we must first analyze why the client is currently cut off from those reinforcers. The primary barrier is what ACT calls experiential avoidance. We can map this barrier directly onto an ABC model, starting with the antecedent. Uncomfortable private events, like intrusive thoughts or physiological anxiety, function as the evocative antecedents. The client engages in avoidance to escape the antecedent, creating a loop maintained entirely by negative reinforcement. The consequence is immediate relief from the aversive private event. This immediate relief strengthens the avoidance response, making the behavior highly durable. Because the avoidance is so effective at providing escape, it's notoriously difficult to extinguish. But this loop has a hidden cost. The energy spent on escape creates an opportunity cost. Constant avoidance prevents the client from emitting exploratory behaviors needed to reach high-priority positive reinforcers. This negative reinforcement trap effectively isolates the client from the sources of well-being. To break the trap, ACT targets the function of the antecedent rather than the avoidance behavior. The goal is to reduce the evocative power of the private event. We aren't trying to change the thought's content. We are altering its function, so the thought no longer exerts mandatory stimulus control over avoidance responses. Once the antecedent loses its evocative strength, the client is no longer behaviorally compelled to escape. Neutralizing the antecedent creates a functional window for new behavior. Without the immediate requirement to escape, the client's repertoire can expand to include exploratory actions. These new behaviors are called value-aligned committed actions. Notice the trajectory. This action connects the client directly to the previously blocked positive reinforcers. This represents a complete contingency shift. The behavior is no longer maintained by the removal of aversive stimuli. Instead, the repertoire is now maintained by the presentation of causative reinforcers. When these actions are engineered to contact dense schedules of reinforcement, they become naturally self-maintaining. The client moves from a restrictive loop of escape to an expansive loop of access. This contingency shift provides measurable evidence that a client has achieved the state defined as well-being. For advanced practitioners, we must acknowledge that these private antecedents, our thoughts, function as verbal stimuli. Originally, these thoughts were part of a rigid stimulus equivalence class, where a verbal rule carried the same aversive evocative power as a physical threat. ACT systematically alters these relational frames. By changing the function of the verbal stimulus, we disrupt the equivalence class, stripping the rule of its aversive property without changing the words themselves. Even at this complex level, the process is governed by observable operant principles, proving that mentalistic explanations are unnecessary. For your BCBA exam, the takeaway is clear and actionable. When you encounter ACT on the exam, your task is to identify how the therapy targets observable operant reinforcement. You must actively eliminate any multiple choice options that rely on unobservable cognitive distractors. Focus on the dual mechanism, breaking the negative reinforcement loop to establish positive reinforcement access. These contemporary clinical questions are straightforward if you apply your foundational training in radical behaviorism. Navigate to the BxM education portal through the link below, complete the Level 3 quiz POC, and apply this operant logic to secure your passing score.